Good afternoon, everyone, and thank you for joining us today. My name is Katy Stubbs, and I'm from the Public Engagement team at Alzheimer's Research UK. I'm delighted to welcome you here this afternoon for the fourth event in our Lab Notes online series. These events are a chance for dementia researchers to share their work with you and to answer the questions you put to them. This event and others in the series are being recorded, so don't worry if you can't make one, as you can watch them back later. We've also turned on the live subtitles feature in Zoom today to help those with hearing problems follow the event. It should be noted that the subtitles are computer generated and so won't be 100% accurate, but if you would like to turn them on or off, you can find how to do that in the button that says CC in the black bar at the bottom of your screen. So before we get going, we're really interested to know a bit more about you and your motivations for attending today. So we're just going to pop a few poll questions on your screen now. And these questions are just asking a bit about how you feel your knowledge of dementia research is and your reasons for attending today, as well as if you've joined us before for an event, either online or in person. So I'll just give you a couple of moments to fill that in. Okay then. So if we've got a good number of people who filled that in now, I wonder if we could have a look at the results. There we go. So people are rating their knowledge around average. Hopefully you'll learn something today and feel that it's a bit improved afterwards. We've got a good mix of people attending because they have a friend or family member with dementia, quite a few people whose work is related to dementia. And we've also got a mix of people for whom this is their first event and also people who might have come along before. So thank you very much for coming along, whether it's your first or you've been a regular for a while now. We really appreciate having you come along. So let me just get my quick introduction slides up and we can crack on with the event. So the plan for today is first a quick introduction from me before you'll hear two talks, one from Professor Brian Green and one from Aoife Sweeney. You may notice we've had a change to our planned speakers. Unfortunately, Emma Cunningham, who was meant to speak today, actually she's had a baby. She had a baby yesterday, a little bit earlier than planned. And so Aoife has stepped in to give her presentation because Aoife works very closely with Emma. So the topic will be the same, just a different speaker. After the talks, we'll then move on to the Q&A session and we'll try to answer as many questions as possible in the time we have. Many of you submitted questions in advance and you can also ask questions during the event. To ask a question, click the Q&A button at the bottom of your screen, which will bring up a box where you can type your questions in. So first, a little bit about Alzheimer's Research UK and particularly an area of our research. So we're a medical research charity, which means that we provide funding for projects in labs and clinics, which are trying to understand the biology of the diseases that cause dementia, and to find new and improved ways to reduce the risk and to diagnose and treat dementia better. As well as this, we do lots of work providing information about dementia and research and supporting people to get involved in research studies. So I just wanted to briefly tell you a little bit more about that work before our speakers get going. So our information services team produce a range of information, whether that's booklets, web pages and videos that talk about different topics. This includes booklets on different types of dementia, as well as about key areas and topics like treatments and how genes are linked with the condition. When we do these events in person, I normally have booklets with me that you can take away. And I know many people do prefer reading booklets than information online. So if you would like, you can actually order the booklets completely free of charge. You can do so by calling us up or on our website. And we're just popping the link in the chat now to give you where you can find out about ordering this information. We also provide these booklets in bulk for free as well. And so you might find them in places like GP surgeries, memory clinics, and also in pharmacies. So if you would like to have lots of booklets for an event or you work in one of these places, do get in contact and we'd be very happy to help you. Our team also run the Dementia Research Info line, taking questions about dementia and research into the condition. As a research charity, we don't provide care and support services, but the team can signpost you to the right sources of support if you are not sure. They're available Monday to Friday during working hours, and they get back to inquiries over the phone, over email, by letter, and also on social media. So do get in touch with them if you have a question and you're not sure where to turn. They also sign people up to something called Join Dementia Research. And this is a system whereby you can register your interest in taking part in research studies. And researchers will get in touch with you if they're looking for people like you to be in their studies. Since it began in 2015, nearly 50,000 people have joined a study through Join Dementia Research. And while the pandemic has affected research studies, there are still 64 open to recruitment currently. But what does taking part involve? Well, the studies really vary, and so what involves for somebody taking part can vary. It might be surveys or questionnaires. Some can involve tests like blood tests or brain scans, and others are trialing potential treatments for dementia. And you don't need a diagnosis of dementia to sign up. Actually, everyone is welcome to sign up. Many studies need carers or family members, and also need people without a diagnosis for what scientists can call the control group. So by signing up to Join Dementia Research, you're not obligated to take part in any of the studies that you might get contacted about. You can decide on a case-by-case basis. And we do hear from many people that being involved is really valuable, and they feel they're contributing to research efforts to improve the lives of people with dementia in the future. So we've put links to Join Dementia Research in the chat as well. You can also call our Dementia Research info line, who can explain more about it and help you to sign up. So getting involved with research is just one way to support our work at Alzheimer's Research UK, and more generally, dementia research efforts. There are a range of other ways in which people can support our work, whether that's through volunteering, donating, leaving a gift in your will, or attending an event like this today and telling others about research. I want to say a huge thank you from everyone at the charity for your support. It's really, really appreciated. So this Lab Notes event and the others in the series are brought to you by us along with our research network. And we provide funding to our research network to support scientists to carry out small projects, get pieces of equipment, and to support them in networking and collaborating with others. Before the pandemic, each centre would organise an annual event to share their work with people in the local area. And so we've worked with them to bring these events online. At this event today, you'll hear from two scientists in our Northern Ireland Research Network. Professor Brian Green is the coordinator of the network in Northern Ireland, and he will share some of his research. And then we'll hear from Aoife Sweeney, who will talk about studies into the link between delirium and dementia before we move to the Q&A session. So without further ado, it's my pleasure to introduce Professor Brian Green and hand over to him for the first talk. Wonderful. Over to you, Brian.
Okay, hopefully everyone can hear me, and hopefully I can share these slides with you. Okay, if you could just let me know that's working okay.
Yep, they're up.
Okay, great, thank you. So hello everyone. My name is Brian Greene and I work in Queen's University Belfast in Northern Ireland. And I'd really like to thank Katy and the organisers for the opportunity to speak this afternoon about some of the work going on within our network centre, specifically within my research group. And the theme of today's session is on delirium and dementia, and our resident expert on this topic is Dr. Emma Cunningham, who is a consultant geriatrician in the Belfast Health and Social Care Trust and a clinical lecturer here in Queen's. Now, unfortunately, as Katy has already told you, Emma has been called away quite urgently, and so we have Aoife Sweeney, who is working on the delirium projects and who will stand in for Emma today. And I'm very fortunate myself to also have been involved in delirium research. So myself and colleagues are really grateful to have received research funding from Alzheimer's Research UK in the past and currently, and really this funding has been instrumental in exploring new avenues of research to further our scientific understanding of dementias. So hopefully my slides move. Yeah, okay. So now at this point, I'd like to point out that I'm a scientist and I'm not a clinician. I work by the laboratory bench and not by the bedside. I'm Professor of Molecular Nutrition within the School of Biological Sciences, Institute for Global Food Security at Queen's. And my specialist area really is in biochemistry, which really means that I want to understand what's happening with dementia cases on the level of individual molecules and in terms of cell processes. So over the last few years, we've been able to develop new ways of furthering our understanding and how different forms of dementia manifest themselves on a molecular level or at the level of molecules. And my research group's specific area of expertise is really in the measurement of molecules. We use sophisticated instruments called mass spectrometers to identify and to measure the exact amounts of particular molecules. And we then compare these levels in different circumstances, particularly in dementia, comparing dementia against control cases, for example. Now, you might think that that's not a particularly unique capability, but we specialize in measuring many, many, many different molecules simultaneously. That's our area of specialism. And the types of molecules that we measure are generally referred to as small molecules. And what that really means is that we typically measure molecules that are called metabolites. And these are molecules which really are the fundamental currency of our cells. They're converted and interconverted into other things within the cell. And really the whole concept is around this word called metabolism. And metabolism really is a complex network of chemical reactions that really the cell uses them to generate energy for itself and to generate all the chemicals that cells need to survive. And we use things called metabolism maps to really understand the processes. Now, they're normally extremely complex and may be quite scary looking. So for my next slide, I'm just showing you now a diagram that was actually created by an artist called Richard Wheeler. And it likens metabolism to journeys on a subway system. And each track or route on the subway is something we would call a biochemical pathway. And each of the stations on the subway route, they are metabolites, illustrated as metabolites. So what we do is we use a technique called metabolomics, and it measures what's actually going on as many of these stations as possible. And we do this by attempting to just measure as many as possible, as many metabolites as possible. And we want to know if there are particular problems in any parts of this subway system or our metabolism system to find out if there are any places where there are blockages in pathways. We want to know, is there any where there's a buildup or an accumulation of particular metabolites? This gives us clues about the function of cells and whether it's been impaired or not, and perhaps reveals places where we might be able to intervene to correct these problems. Now, of course, in reality, biochemical pathways are actually much, much more complicated than the subway map I've just shown you. And we might present them a bit more like this and attempt to measure many, many more metabolites than I've showed you before. So what my group have been doing over a number of years is just to try to identify how dementias alter our metabolic pathways. And we've done this using samples provided from patient volunteers and family members. So for example, here locally at the Belfast City Hospital Memory Clinic, using blood samples, we've been able to identify signatures that indicate persons with mild cognitive impairment who are at greater risk of developing Alzheimer's disease. And we've also been able to do this in very similar samples obtained from international cohorts as well. And using brain samples provided by an Alzheimer's Research UK initiative called Brains for Dementia Research, BDR, we've been able to also uncover differences between persons with different types of dementia and uncover issues with brain metabolism. And using samples from the many different rodent models of Alzheimer's that exist, we've been able to follow changes over time as the disease progresses, both in the blood compartment and also in the brain. And there's been an awful lot of new findings coming forward from metabolomics researchers like ourselves from around the world about dementia. They've furthered our scientific understanding of dementia. First, really, this kind of work has established that late onset Alzheimer's disease, the main cause of dementia in the elderly, is in fact a metabolic disease. Secondly, it has uncovered issues to do with cell metabolism, that the energy that the cell uses is profoundly disturbed in Alzheimer's disease and other dementias. Thirdly, really, that Alzheimer's disease and other dementias affect lipid metabolism, that's fat metabolism. And this makes a lot of sense, given that the brain contains proportionally greater levels of fat than most other tissues. And the destruction of these brain cells really can alter lipid profiles. Fourthly, that really there's been that gender is actually has quite a large influence in the changes we observe. When a dementia is present, certain molecules are more likely to be altered in females, and other molecules are more likely to be altered in males. And finally, really, that key genes associated with Alzheimer's disease risk, for example, the ApoE gene, are influential in metabolism as well. So when analyzing any of our samples by these techniques, we need to account for the subject age, their gender, and genotype, because these represent risk factors for Alzheimer's disease and have strong influences on metabolism. Now, although we have observed many differences in the profiles of dementia patients and in healthy, cognitively normal persons, turning this metabolism information into a meaningful test for Alzheimer's disease or any other dementia has proved extremely challenging, not just for ourselves, but for all others who've attempted it around the world. We see different patterns discriminating dementia in different populations. And also the differences we see are not always consistent, and they can largely be attributed to differences in diet and in genetics. And many of the changes are unlikely to be specific to the pathology. However, one of the more consistent observations that we and several others have seen is that there's an important impairment in something called arginine metabolism in cases of dementia, particularly in Alzheimer's disease. And what I show here in green are some of the things we've measured that are different in Alzheimer's disease. Now, of course, one of the greatest challenges in dementia research is that its onset can be subtle and can take place over many, many years. And we also don't have any routine tests that can give us an early diagnosis. So although we don't yet have any disease-modifying drugs, if we knew who could be diagnosed early, we can reverse those pathological changes through other means, through diet and lifestyle and other ways. It could be possible to prevent and delay the development of dementia by just modifying risk factors. So, but it's also a problem for researchers too, not having early diagnosis, because the samples that we obtain are often, later in the disease. They already have symptoms present. And if we were able to access samples before symptoms were apparent, then we could better understand and detect the disease at the earliest stages. So it could help us really improve potential for diagnosis or devise new treatments. And this is where delirium comes in, the topic of today's, the focus of today, and that Aoife is going to give a much fuller explanation of about what delirium is. And I hope I'm not giving too much away of a spoiler here, but I just want to define very briefly what delirium actually is. Delirium is a state of mental confusion that normally happens if you become medically unwell. And it's really referred to as an acute confusional state. And it's normally caused by things such as illness, surgery, different medications, and it quickly disappears again whenever whatever is causing it improves. Now, the reason we are so interested in delirium is that delirium is a marker of brain vulnerability. It's associated with increasing age, and it's also associated with pre-existing cognitive impairment. And furthermore, it's been shown that biomarkers of Alzheimer's disease differ in subjects who experience delirium compared with those who do not. Now, I should emphasize that these biomarkers of Alzheimer's disease are not changed to anywhere near the same extent as they would be in persons with confirmed cases of Alzheimer's disease, but it does indicate that the two conditions have an association. We've recently analysed samples from the clinical cohort established by Dr. Emma Cunningham and colleagues at the Belfast Trust, and it was an observational study focused on post-operative delirium. So this is people who exhibited delirium after having routine surgery. The participants in this were all under 65, and they were all having routine hip and knee surgery, and they didn't show any signs of dementia. We took a small sample set, what we would call a nested case control cohort, which compares either persons who experienced delirium after surgery or persons who did not experience delirium after surgery. And the persons who experienced delirium had altered levels of amyloid beta 1 to 42, which is a marker of Alzheimer's disease, in their cerebrospinal fluid. Using our techniques, we found that at least 3 molecules indicated here in red in the biochemical pathway that we're interested in, arginine metabolism, were affected, and they were actually all significantly increased. And furthermore, they were really all very good markers of delirium that indicate persons who are at greater risk of experiencing a delirium. And they could be enhanced by combining them with the measurements of amyloid beta, the Alzheimer's disease marker. So we're among the first to have shown this, and it has been peer reviewed and it has been published, and the sample size is relatively small, but there are reasons to believe that this may be linked to Alzheimer's disease. And the challenge for us is really to find sufficient funding to prove this in larger numbers of people from other parts of the world. We were extremely pleased when we saw this very specific call launched in the United States, inviting researchers to propose their ideas to clarify the relationship between delirium and Alzheimer's disease and related dementias. So we got together with some colleagues in the US and colleagues in University College London, and we won a large amount of funding to really examine this whole area of arginine metabolism in a much more detailed way in patients from the UK and Europe, and also to build a really large delirium patient cohort in the USA. And so this project is really only just beginning now, and we've recently appointed a researcher to work on this. And delirium is a relatively common condition, and many who experience a delirium episode may not develop a dementia. However, we're not really at a stage where we can screen the entire population en masse for dementia. So as scientists, we really feel that post-operative delirium, where we can examine brain vulnerability in a detailed and controlled way, gives us a real opportunity. So at this point, I'd like to thank you very much for taking the time to listen to my presentation. I'd like now to introduce my colleague Aoife Sweeney, who's filling in for Emma today, and who's filling in for Emma today. Aoife's research interests include delirium, Parkinson's disease and dementia, and her PhD research investigated the ability of brain activity recordings, or EEGs, and machine learning to identify mild cognitive impairment in Parkinson's disease. She's currently working as the postdoc researcher investigating the link between postoperative delirium and dementia here at Queen's, and is working with Dr. Emma Cunningham. So over to you, Aoife.
Thank you very much, Brian. Thank you for a great introduction into the work that's going on here in Northern Ireland, particularly with dementia and delirium. So I'm going to share my screen now with my slides, and hopefully all will be well. Okay, so hopefully everyone can see that. But delirium is a short-term change in thinking. It's very unpleasant for the person experiencing it, as they may see or hear things that aren't there and they may not know where they are. It's also distressing for their family members, as they may see how distressed their relative is and they may worry about when they're going to get back to normal. It's also very difficult for staff looking after these people. And in addition to that, delirium raises the chances of other things occurring. So if a person is in hospital with delirium, they're more likely to fall and they're less likely to eat and drink as they should. They may also have difficulty communicating their pain effectively, so they might not receive adequate treatment for that. But the worry with delirium is that it's associated with increased likelihood of cognitive decline, dementia, moving to a nursing home, and death in the years following delirium. So if we think about two gentlemen aged 70 years old, so Terry and Tom, and they've both broken their hips. Terry develops delirium, whereas Tom does not. So this means that Terry is more likely in the coming years to develop dementia, to move to a nursing home, and to die. But this isn't the whole story, and we need to find out more. Does the delirium do something to Terry's brain? Or is it simply a reflection that Terry's brain was more vulnerable in the first place? So that's what we're going to talk about today. It's the link between delirium and dementia and what post-operative delirium can tell us about dementia risk. As Katie and Professor Green have said, this was supposed to be given by Dr. Emma Cunningham, but she had a little baby girl yesterday, so I'm standing in as replacement. I'm a postdoc working on the project, but I'll introduce you to everyone involved in the study. So this is Dr. Cunningham here in the top left corner. She's well suited to research this, as she spends half her time working as a consultant geriatrician in the Belfast Trust and the other half as a researcher at Queen's University Belfast. She, in her clinical role, focuses on memory clinics and diagnosing people with dementia. And previously, in her research and clinical roles, she has worked in elective orthopedic units as a physician. She has a PhD in postoperative delirium. She's published on the topic, and she's a member of several executive committees in relevant professional bodies. A lot of the work that I'm going to talk to you about was conducted as part of an observational study, and the architects of that study were Dr. Bernadette McGuinness, Professor Peter Passmore, and Professor Danny McCauley. And then here's Professor Green, who you've seen, who conducted a lot of the lab analysis for the study. There's Professor David Beverland, who's the orthopedic surgeon, who conducted a lot of the hip and knee replacements and also is very active in terms of orthopedic research. This is me, I'm a postdoc with Dr. Emma Cunningham. This is MJ, who's a second-year PhD student working on the project, and she's supervised by Professor Green and Dr. Cunningham. And then Emily Bowman, who's a first-year PhD student supervised by Dr. Cunningham and Professor Danny McCauley. And then we've honorary lab member Dougal here, who's a very fluffy boy. And thank you to the sponsor, Belfast Health and Social Care Trust, to our colleagues and collaborators, and of course to funders. So Alzheimer's Research UK are funding a lot of this work. And there's also the National Institute for Health, Dunhill Medical Trust, and the Belfast Arthroplasty Research Trust. So to tell you a bit more about delirium, it's a short-term disturbance, and it comes from the Latin word to go off the ploughed furrow. So the concept of delirium has been around for thousands of years, dating back to Hippocrates, who noted that when you're sick and when you have delirium, it doesn't bode well. Delirium is a very acute thing. It develops over hours to days, and the person might have trouble following conversations, paying attention. They may see, hear, or imagine things that aren't there, and they may be drowsy and agitated. It will usually resolve itself in a few days. But what do you need for a delirium? So for a delirium to take place, you need a vulnerable brain and you need an insult. So a brain is most vulnerable at the extremes of life. So babies and young children can develop delirium, but we'll not cover that today. And also older people. So increasing age raises your risk of having a delirium, but also if you have dementia or a dementia causing process, that places an additional risk on top of your age for developing a delirium. So if we take, for example, an older lady who has dementia, something as minor as a urinary tract infection may cause her to become delirious. Whereas for a younger person with a healthy, robust brain, it may take something as serious as a road traffic accident and a stay in ICU to cause delirium. So the more vulnerable a brain is, the lesser the magnitude of the insult or precipitant needed to cause a delirium. So delirium is common where brains are vulnerable. So you see delirium in older persons' wards and hospitals, you see it in nursing homes, and you also see it in places where the insult is high, so like in intensive care units or after major surgeries. Delirium can happen after any surgery, but especially in older people. So for example, in 2019, over 150,000 people aged over 60 had a hip or knee replacement in the UK. Of these people, 1 in 6, that's over 27,000 people, will develop delirium. So we're very interested in finding out, is there a link for these people between postoperative delirium and dementia, because it's a large number of people every year. So dementia is different to delirium in that it's a longer term disease, it's a clinical diagnosis, and it's progressive. And when you're thinking about dementia, it's helpful to break cognition down into 3 categories. So the first category is normal cognition. If we think about, your cognition is perfectly normal, the umbrella works, it keeps the rain out, you're able to do the things that you want to do day to day. Then mild cognitive impairment is when there is some objective cognitive impairment. You can measure it using memory tests, but the person can still carry out their day-to-day activities. So frequently, a spouse of a person might say that, they're forgetting things or they're repeating themselves. But when you ask, is there anything they cannot do because of their memory, they say no. So the person is still able to use the phone, use their computer, drive, do whatever they want to do day to day, but there is evidence of cognitive impairment. Whereas dementia, on the other hand, is a progressive new memory problem, which means stops the person doing the things that they used to do because of their memory and thinking. So the umbrella isn't doing what it should and it's letting the rain in. So dementia, it's when somebody can't do things because of their memory and not because of a physical problem such as arthritis or a stroke. So what do we know about dementia? So this is kind of a best estimate graph of what we know about dementia. There is a lot we still need to learn because there's overlaps between these different dementia causing diseases and there's a lot to find out. But what these different dementia diseases share is, number one, an abnormal accumulation of protein or proteins. So in the case of Alzheimer's disease, which makes up or is responsible for the majority of dementia, there's an abnormal accumulation of plaques of amyloid and tangles of tau. Whereas in dementia with Lewy bodies, there's an abnormal accumulation of alpha-synuclein. And the second thing that all these dementia-causing processes have in common is that different areas of the brain shrink or die at an accelerated rate. So as we age, all of our brains shrink, but not to the rate that is seen in dementia. So for instance, in Alzheimer's disease, it's the hippocampi that shrink and they're responsible for the storage of memories. Whereas in frontotemporal dementia, it's the frontal lobes that shrink and they're responsible for language and for inhibition. So there's a lot that we still need to know. And dementia, by the time a person shows memory problems or symptoms, so if we consider that green shaded area here, as Brian said, the changes in the brain are taking place over a number of years. And there are different ways that we can try and measure that. We can try and measure the accumulation of tau and amyloid using spinal fluid and blood tests. And we can try and measure the shrinking of the brain using MRI scans and PET scans. And this is the area that we're interested in here. If you are one of the 1 in 6 people that develop postoperative delirium, does this mean that you are somewhere on this trajectory? Does it mean that you have a dementia-causing process going on that you know nothing about? So that's where our work is focused on. So in order to measure this, Dr. Cunningham conducted a study over 9 years ago. So between 2012 and 2014, patients who were admitted at Musgrave Park Hospital in Belfast for planned hip and knee replacement surgery were approached. And these patients were aged over 65 and they did not have dementia. So they were approached and asked if they would like to take part in the study. And thankfully, a number very kindly did. And they completed memory and thinking tests prior to their surgery and prior to anesthetic. And then at the time of surgery. The beauty of this study is samples were taken, but with no kind of extraneous procedures for people to have to go through. So when the person was getting a spinal anesthetic, which is necessary for their operation, the anaesthetist needs to check that they are in the right place and that they have a good flow of fluid. So we were able to take a sample of this fluid, and then similarly, when a person is having surgery, they have a line in the back of their hand, and we were able to take a blood sample from this. The person then had their anesthetic and had their surgery, and Dr. Cunningham assessed people every day for the first 3 days. So on days 1 to 3, asked them questions about how they were, did they know where they were, and different delirium screeners. And then following that, patients were discharged. So 315 people took part in total, and their mean age was 74 years. So what did we find? So 1/3 of the people in this cohort who were aged over 65 had a spinal fluid pattern which resembles that you might see in a person with Alzheimer's disease. So none of these people had dementia, but yet 1/3 of the cohort did have this Alzheimer's disease spinal fluid pattern. And then 1 in 6 people in our study developed delirium. And of those who did not develop delirium, 1/3 had the Alzheimer's disease spinal fluid pattern. And in those who developed delirium, 2/3 of people had the Alzheimer's disease spinal fluid pattern. So we can say that Alzheimer's disease spinal fluid pattern is more common in people developing delirium after surgery. But what does that mean for the 40% of those who develop delirium who don't have this Alzheimer's disease pattern? And what does that mean for the 1/3 of people who didn't have delirium but do have this Alzheimer's disease spinal fluid pattern? So it's clear from this, or from these findings, that Alzheimer's disease biomarkers don't tell the whole story and that there's more going on. So we need to look for more novel Alzheimer's disease biomarkers. And this is just a slide from a very useful website called ALZ Forum. And I think the website's on the bottom, it's ALZ Forum. And the yellow and blue circles depict spinal fluid markers that are associated with dementia. And the red and purple circles depict blood test markers associated with dementia. And the bigger the circle, the more reliable or more accurate the marker. So the purpose, or why I'm showing you this slide, is to say that we have stored samples of CSF and blood, and various different novel markers are being looked for. So for instance, Professor Green just mentioned the metabolite analysis that was conducted on our spinal fluid pattern, on our spinal fluid samples, and there's lots more in the works as well. So it's important to measure these, because although obviously Alzheimer's disease biomarkers are important, it's not telling the whole story. So this tells us about what people were like at the time of surgery. But we need to put this in context. What does that mean for the person who develops delirium? What can they expect from their memory in the coming years? In order to do this, we need to have a thorough description of perioperative conditions. We need to have a thorough evaluation of baseline neurodegeneration or brain vulnerability. And we need long-term cognitive follow-up. So to that end, we are conducting a follow-up study, and this study is funded by Alzheimer's Research UK. So we are very grateful as it's very meaningful research. But 315 people took part in the original study 9 years ago. Their age was 74. So unfortunately, 53 people have died since taking part in that study, which meant there were 262 participants to contact last year. 85 declined to take part, but 170 people have consented and have completed phone interviews. So these phone interviews, they consisted of health and lifestyle questionnaires, and then also some virtual telephone cognitive assessments. So it's kind of a placeholder until we're able to see people in person. And later in the year, we will conduct in-person visits where the person will be asked to repeat the cognitive assessments they did 9 years ago before and after their surgery. And we will also ask them for a blood sample. So we plan to do that as soon as the coronavirus restrictions are lifted and it's safe to do so in Northern Ireland. So therefore, with this study, we're covering all these needs of trying to quantify brain vulnerability, describing what happens at the time of surgery, and conducting long-term cognitive follow-up. So hopefully this will enable us to better inform people of what to expect from their memory in years to come. And the lead on this study is, and resident delirium expert, is Dr. Emma Cunningham. She couldn't be here today, but her contact details are there. And my name is Aoife Sweeney. I also work on the project, so please feel free to direct questions to me. But that's what I have to say about that. So back to Katie, I think, for questions or question and answer session.
Yes, thank you so much, Aoife, and also Brian. Your talks were really, really interesting. So just wait for Aoife to come back on screen and we can go through to some questions. So we've had some come through during the talks, but also we've had some ahead of time. So I think one of the questions we had come through quite a few times before the event was about how in this event, Aoife, you've spoken about looking at delirium after people have had surgery, but I wonder if you'd be able to tell us a little bit about, particularly in older people, what other things might mean that somebody then develops delirium?
Sure. So the reason, okay, so to get a delirium, you need two things. You need a vulnerable brain and an insult or precipitant. So if a person is older, and especially if they have dementia or memory decline, what they need to cause delirium is smaller than what would be for a younger person. So for example, for a person with dementia, it might be something like a urinary tract infection. Any kind of mild infection may put a person at risk of delirium. Things like other types of surgeries, if a person was in for heart surgery, if a person had sepsis, hip fractures are a big one as well. And it's the magnitude of the insult is less if the person has a more vulnerable brain. So the reason, a good thing about this study was that it was kind of a homogeneous insult. So it allowed us to learn some things about delirium with a relatively consistent kind of insult or anesthetic and pain relief that the person had to go through. So it's just all about that brain vulnerability. It leaves a person open to delirium.
Thank you for explaining that. And so I think you've kind of covered this in some of the things you've said already, but we've had a few questions. So the first one is somebody saying that their husband has Alzheimer's and he's had some infections over the past year, which have then triggered delirium for him, and they're asking, would his Alzheimer's have been a factor in his delirium? Like, I think from what you've said, basically, yes, that's the case.
I think so. Unfortunately, yes, it just leaves him a bit more vulnerable to developing delirium.
And as you said, the problem with dementia and both delirium actually is that people aren't able to communicate their needs. They might not be able to say, I'm in pain or I'm in discomfort, and that is a very difficult situation.
Absolutely. And I think it's difficult even for it to be identified because a lot of the symptoms are overlapping. So like one of the tests for delirium is that of inattention, like naming the months of the year backwards, but a person with dementia will also struggle with that. So I think like that's where having family involvement or having somebody there being able to confirm that the person is a bit different than usual. But it's hard because yes, you don't want, the risk is that the person may be dehydrated and they're unaware, they may have greater pain that's not being attended to. So it is very important to identify and screen for, and hopefully we'll learn more about it in the course of the coming years.
Yes, yeah. And I think that brings me on to the next question, which I guess is about the directionality of the link. My understanding is that it's two-way. So the question's asking, is delirium potentially diagnostic criteria of Alzheimer's by itself if it was severe enough, or would other symptoms need to be present? And well, my understanding is that what delirium might do is reveal actually that somebody might be at those early stages of something like Alzheimer's, and then that's what causes the diagnosis, but actually it's just kind of unmasked what was already happening.
Yeah, so I think that is a debate that's out there. So I think the main question that we're trying to answer is, does delirium itself cause a neurodegenerative process, or the more likely or the reliable bundle of evidence would suggest that delirium is highlighting that there's a neurodegenerative process going on. So I think, there's a lot of evidence which suggests that is the case, but there is a study from Dan Davis at UCL, the Vanta study, I think it was with brains post-mortem, and they looked at their notes when they were alive. And it does seem that delirium, it does have an effect, but it likely skews or maybe maybe skews a person's trajectory a wee bit. Maybe it might like speed things up a little bit, but the evidence would seem to suggest that delirium just unmasks, as you say, or highlights that something is going on rather than causing it in itself.
Thank you. Yeah, that's a really good explanation there. I've got a question here. I'm not sure whether you'll be able to answer. I'll ask it. Is there a national standard framework to screen patients for delirium in hospital?
So a lot of hospitals would follow guidance from NICE guidelines. They're the National Institute for Clinical Excellence. They do have guidelines in place. And also there's excellent guidelines and recommendations from the Scottish Intercollegiate Guidelines Network. I hope I have what those words stand for correct. But they have a guideline, it's guideline 157. And there's a lot of work, I think, and there are recommendations there. So there's recommendations about trying to limit or prevent deliriums and how to not manage it both pharmacologically and non-pharmacologically. So there are recommendations there. Regularly used is the confusion assessment method, and also the Richmond Agitation and Sedation Scale, and other global measures are useful, such as the mini mental state examination for global cognition, and months of the year backwards is also a popular one. But there is lots of recommendations out there, but I think that rates of diagnosis or identification can definitely be improved.
And with that, there's a question here about catheters and how they are routinely used for older people who might be retaining urine in their bladder if they have Alzheimer's, and how a catheter itself might be something that could trigger delirium. But I guess this is probably a question that Emma, as a clinician, would be really well placed to answer. But I guess it's that balancing of the retention of the urine might cause delirium, but also having a catheter might cause delirium. It's these really like specific, I guess it's case by case that doctors have to make these sorts of decisions.
I think so. I think it's a very fine balancing act. So the same can be said about pain and painkillers and delirium. Pain itself can cause delirium, but then using too many painkillers or too much painkiller can also precipitate that. So I think it's a very difficult line to walk. And I think, yeah, it's difficult for clinicians, and just because somebody develops delirium doesn't mean, you know, you can have amazing care, and people who carry out all these best practice guidelines and trying to minimize risk, but it can still happen. So I think it is difficult, and that's the, you know, one of the hard things about studying delirium. It can happen as a result of so many things in so many different areas of the hospital.
Yeah. Another question we've had is about how long delirium can last. So I think you mentioned about it being quite an acute thing, but can it in some cases last longer? So somebody's asking here where they're aware of someone where it's been going on for about 6 months.
So usually it resolves within a few days, but there are cases, and particularly with people who may be more frail or may have dementia, where it can because the brain is more vulnerable, it can take a longer time to recover from it. So there are cases of older people with dementia who may have delirium for months. It is less common. Usually the amount of time is a few days, but yes, that can happen. And that's like very unpleasant, obviously, for the person, their family and staff.
Yeah. A slight change of tack here. We've got a question for you, Brian, about, so you mentioned some of the metabolites that you're interested in and trying to measure, and talked about, I think it was diabetes that you mentioned. So the questions, let me just find the original question again. I think it was about 2 specific markers. So are there, maybe you can just expand on some of the markers around diabetes and their links with dementia and the kind of work you're doing there.
So we're not doing any work on diabetes. I didn't mention diabetes deliberately so, but you know, there is obviously associations between diabetes and dementias, and the one very strong area is where type 2 diabetes is a risk factor for the development of vascular dementia. That's very clear cut. Okay, so we know that there's a good relationship there between the diabetes that develops and the damage that can happen to blood vessels in the brain, and dementia can result from that. Now, there's also been some associations between diabetes and the likes of Alzheimer's disease, but whether you could use, you know, insulin or HbA1c as a common biomarker, no, I don't think so. I don't think there's any evidence that there's that kind of, you can use those diabetes biomarkers to help with dementia diagnosis. But what I would say is that there's been a few associations. Obviously, insulin metabolism is impaired in Alzheimer's disease, and there are some diabetes drugs that are being pursued as potential Alzheimer's treatment. So, for example, there's a trial going on called the ELAD trial in the UK, which is looking at compounds around a molecule called GLP-1 that are used for treatment of diabetes that potentially could be used for the treatment of Alzheimer's disease, but that's not working through precisely the same mechanism. So there's a different reason why it might be effective in Alzheimer's disease. Nonetheless, there are some associations there, but type 2 diabetes is very much more widespread, common condition than dementia, and I wouldn't want people to rush to conclusions to think that the two are the same in any way.
Yes, thank you for that. So we've had a question, I'm not sure if we'll be able to answer it, but it's asking, can we put depression into the equation? So it's also a condition that's not always picked up, not always screened very well for. I don't know, Brian, if you know from like a kind of pathways biochemical aspect, if there is any link. I know that in terms of risk, there's some indication of link, but I don't know if either of you could comment about a link between depression, delirium and dementia, all three or just two of those?
Well, I'm not the clinician, so I can't speak too much about how it affects the patient, but in terms of depression, a lot of the treatments used for depression are serotonin reuptake inhibitors and things like that. Their mechanisms are focused on very different things to treatment of Alzheimer's disease. So we know that obviously depression can be a symptom of dementia, but whether I wouldn't want anyone to think that the depression and dementia are the same.
Yeah, thank you. Sorry, Aoife.
Yeah, as far as no, it's okay. As far as I'm aware, and I also want to state that I'm not a clinician, I don't think that having depression predisposes somebody for delirium, as far as I'm aware. And I don't think that it was a predictor in our cohort of later, of post-operative delirium. Having depression may lead people to score a bit lower on memory tests, just due to things like affect and motivation. But I don't, as far as delirium is concerned, I'm not aware of any link, but I could be very wrong.
No, thank you. So we've had a few kind of more, I guess, specific questions come through, and I think they just touch on a similar point. So somebody asking about somebody experiencing delirium after a stay in hospital and some surgery, and then ultimately being diagnosed with Parkinsonism and Lewy body dementia, and asking whether the delirium could have exacerbated the dementia that was beginning to develop. Similarly, somebody else is asking about somebody who had a fall and then fractured their leg and then had delirium and then had some mild cognitive impairment before the fall. So in both these cases, would the delirium have exacerbated what was already happening there?
I don't think that we have a lot of data to say that, delirium is associated with increased risk of cognitive decline and dementia, but the data would suggest that is because it's highlighting a cognitive process that was already going on. That study that I mentioned from UCL, they did point out that they found that delirium did have a pathophysiological effect and that it did aggravate or increase the speed of the trajectory, but there's not a whole lot of data out there. It's not, I should have said earlier as well, that not everyone that gets delirium will get dementia. It's just an increased risk compared to people of their own age. But I think that the evidence suggests that it's uncovering a process that was already there. So I don't think so, but it's just, I suppose, a highlight that there's a dementia causing process at play.
Yeah, thank you. Another one maybe for you, Brian, is there a link between statins and Alzheimer's at all?
So yes, it's a good question. I mentioned in my talk that lipids or fats are affected and disturbed in dementias, and that's very clear from many, many groups around the world that the levels of lots of different lipids are altered in dementias. Now, we haven't seen a very consistent pattern with that. It seems to differ quite a lot when you move from cohort to cohort. And we think a lot of that's down to diet, okay, because we obtain an awful lot of the fats from our diet. And in different parts of the world, we eat different things and we get different lipids as a result of that. So the question about statins is interesting because many people are taking a statin to correct their blood lipid profiles. And really that's all to do with, you know, vascular benefits you can get from that, you know, reduce potential for heart disease, vascular dementia and other conditions. But there have been a couple of studies that have shown a very modest potential benefit in reducing Alzheimer's disease risk with consuming or taking statins. So it's possible that statins could be beneficial. We would in our studies check who has been taking a statin to see whether that might affect our results. So it's something we do look at, but we don't have any evidence, you know, in our studies that statins directly linked with either delirium or dementia, unless Aoife knows of something on the delirium front more so than me. But certainly there's potential benefits for your brain in taking statins. There's some evidence of that.
Yeah, I guess it speaks to that message that we often talk about of what's good for your heart is good for your brain. You need a really good blood supply to kind of look after your brain. It's very active. And so actually anything that can improve the heart health and your cardiovascular system is likely good for the brain. So I'm just conscious that we are a few minutes away from 4 o'clock now. And so I just want to thank you both, Aoife and Brian, for your excellent talks and for answering everyone's questions. It's been really wonderful to have you.
Thank you very much for having us and for supporting this research. And thank you to everyone that came along, and thank you for the questions. And of course, I think you'll get a link to the talk afterwards, but feel free to contact me or Professor Green and volunteering you with questions that you have afterwards.
Yes, thank you very much, Katie, and all the team for running today's event. I think it's been very helpful to be able to present the work that we do. It's ARUK funded and other funded, but anything that we're doing in the dementia front, it's really good to be able to get that out there and to let people know that there's lots of different pieces of work going on, and delirium is just one of them, but it's been a nice focus for today.
Wonderful. Well, thank you both so much. If people stick with me just a few minutes longer, I've just got a couple more things to do. So as at the start, we just want to ask you a few more poll questions just to give us some insight into how you found today. So if I just pause for a second while the poll comes up, and this just helps us to know whether you think the events are good, if you'd recommend them to friends or family, if you think you've learned something today, and if you think you might come along again, because we would love to have you. So I'll give you just pause for a minute to let you answer those. Okay, and then if we can get the answers, the responses up, hopefully they're good. Always a bit nerve-wracking at this point. So people would recommend them, which I think means that you enjoyed it and you found it useful, you feel you've learned something, and lots of people want to attend again. So that is absolutely fantastic. Thank you so much for that really good feedback. We'll also be sending a more detailed feedback survey along with the video recording of the event in the next few days. So please do complete the survey, as any kind of insight you can give us into how you found it or any comments, they're really, really useful, and they help us to continue to improve these events. The next event in our series is taking place on the 29th of April at 11 AM, and it features researchers from our King's College London network who will take you behind the scenes of the research labs, showing you the different techniques and experiments they use to understand more about dementia. You can find out more and sign up on our website to join us on the day, and it'll be really exciting to actually see what it's like in the lab. I know we had some questions ahead of time and on the day that unfortunately we weren't able to answer, mainly because we didn't have Emma with her clinical knowledge here. And I know you might be looking for more practical information about delirium. So just putting some links in the chat to Dementia UK, who are a care and support charity. So they have lots more information about delirium and other behavioural symptoms of dementia and some tips for how to take care of people. Our Dementia Research info line is also on hand to answer any questions and signpost to other sources of information support. So please do get in contact with them, as they'll be really happy to help. So just as we close, I want to say a huge thank you to everyone for joining us today. It's been wonderful to have you. I hope you found it really interesting and useful, and that you'll join us again in the future for another event. Thank you and goodbye.